My talk is how to use biomarkers and imaging for patient selection for focal therapy. I have no relevant disclosures to disclose. So we've been talking about who is the ideal candidate, what's the sweet spot for focal therapy. We've been talking all over it, and Dr. Zidana just summed it up really nicely. So what we are trying to aim is to treat patients with intermediate risks for focal therapy. We know that patients with low risk are preferably managed with active surveillance, and a lot of patients with high-risk disease, well, focal therapy may fall short. But there are a couple of patients with what we now call low risk that might benefit from focal therapy. For example, patients with multiple cores, unilateral, patients that have a high percentage of compromise on each core, even if everything is a grade group 1. Patients with high PSA density, speaking that may be something else hidden there that we don't know about. Patients with liquid or tissue biomarkers suggesting that the disease is actually more of a risk than we actually find, and we'll talk about more of that in this talk. Patients with a concerning MRI image, patients perhaps with a Pirates 5 disease or a large Pirates 4 disease that was only found to have Gleason 6 disease on the biopsy may not be a great candidate for active surveillance. And of course, we also have these patients with high psychological burden, as we still call these type of findings cancer. They cannot control the idea of having a cancer and not being treated. And also some patients that we now categorize as high-risk disease may benefit from this. Which patients are these? For example, patients with unilateral and limited disease to an MRI lesion, low PSA density, on the other hand, diagnosed through fusion biopsy. We know that a Gleason 8 found on the lesion diagnosed with fusion biopsy tends to have a higher risk of undergrading if we do a radical prostatectomy. So not all Gleason 8s are the same, and it is my belief that they are not fall all in the same category of high risk. And patients who also reject radical therapies, and also that might be good candidates for due to the localization of the cancer, might also be candidates for focal therapy. So how are we selecting our patients nowadays? We've been talking about risk stratification. Here are a summary of the most utilized risk stratification tools, the DAMICO, the European, the NICE guidelines, and the AUA, for example, and NCCN. But even if there is some difference between them, the reality is that all of them use PSA as the only biomarker. They only rely on H&E, good old H&E, for the tissue interpretation and nothing else. And basically, they all use DRE as the only way to assume gland involvement of the tumor. So I think we've evolved and we have newer ways of assessing risk, even though they're not validated as risk measures. But I think that for selecting patients for focal therapy, our risk stratification falls short. And I'll give you an example. These are two real patients from my clinic. The first one is a 58-year-old man with a strong family history of prostate cancer, presenting with a PSA of 7.2, a non-suspicious DRE, and an MRI with a big 19-millimeter Pirates 5 lesion on the anterior right transition zone, mid to apex, contacts and blurs the capsule on the anterior side and crosses to the left, and a prostate volume of 33 milliliters. He was referred with a TRUST systematic biopsy that only found 3 out of 6 cores on the right with grade group 2 disease, and all the cores on the left were found to be benign. On the other hand, we have a 76-year-old man with a history of 2 negative biopsies on 2010 and 2013, presenting with a PSA of 14, a DRE with a small nodule on the left base, an MRI that suggests an 8-millimeter Pirates 3 lesion on the left peripheral zone at the base that does not contact the capsule but abuts it, and a prostate volume of 112 milliliters. He had a systematic and guided biopsy, revealing that 1 of the 3 cores on the target was a grade group 4, 10% of the core. Another core on the target was grade group 1, and the other one was benign. And he had a systematic biopsy on the other side, finding 1 core of grade group 1 disease, 20%. Now, with a raise of hands, who would counsel a more aggressive therapy on the first patient? At least that's what I did. So the first patient underwent a radical prostatectomy, and the other one underwent focal therapy. But if we use the current risk stratifications, most of them will tell you that the first patient would be a favorable intermediate because they don't use the MRI, they use family history, the risk stratification tools do not use any other biomarkers, and they use DRE as the only CT grading. And the second man, because of the Gleason 8 found on the target, will be stratified as a high-risk patient. So how can we incorporate novel biomarkers and imaging for patient selection? Where there's not much evidence out there on implementation of biomarkers for focal therapy patients, but what we do have is a consensus statement of the Focal Therapy Society published a couple of years ago. And what the consensus revealed is that there is no evidence supporting the use of biomarkers, either liquid or tissue-based nowadays, in selection for patients for focal therapy. But there was unanimous consensus that studies supporting the use of biomarkers are strongly awaited. So the Focal Therapy Society and focal therapy experts are all awaiting the validation of biomarkers for patient selections. Why? Because our currently validated tools are not the best ones to select our patients. And these studies will need to use surrogate endpoints to mortality to allow for medium-term answer. If we are treating intermediate risk patients, that means the risk of dying or progressing to metastatic disease in the near future is very low. So if we use these endpoints to validate these liquid biomarkers for focal therapy patient selection, then we'll have to wait a long time for these results, and then new biomarkers will come, so that those studies will get old. And the biomarker in question will have to be validated as an independent clinical decision pathway changer, apart from our current risk assessment tools. So can we extrapolate the evidence from the validation studies of these liquid biomarkers to our focal therapy patients? The reality is that pre-biopsy MRI and guided biopsy are the backbone for focal therapy patient selection. We've been talking about this all morning. But most liquid biomarker validation cohorts of most available biomarkers nowadays these patients were not subjected to pre-biopsy MRI before. So the reality is that the validation of these, the evidence that led to the validation of these liquid biomarkers, any biomarker you can find in the market, is not really useful and applicable to our patient cohort. How about tissue-based biomarkers? Well, there are a couple out there. We have the Oncotype, which gives you a GPS scores that correlates with unfavorable pathology at radical prostatectomy and tells you about biochemical recurrence, the risk of biochemical recurrence in 5 years. We have the Prolaris that offers prognostic information on all risk groups, has a certain role in prediction of cancer-related mortality as well. And we have the Decipher, which is developed to predict risks of metastasis post-radical prostatectomy, but there are several studies ongoing to validate it on the diagnosis scenario. So if we are actually nowadays in our clinical practice using these tissue-based biomarkers to decide which patients that were initially diagnosed with low-risk disease may benefit from additional treatment, regardless of the treatment type, then I think, it is my opinion, that we can use the evidence that we have nowadays for tissue-based biomarkers for these genomic scores to select patients that might benefit from focal therapy, given that they fall into the other other ways to select patients that Dr. Sidana just talked about. How about PSA density? PSA density is at least my favorite liquid biomarker for selecting patients for biopsy, but is it good enough to select patients for focal therapy? Well, we know, and the evidence is growing, that PSA density is complementary to PIRATs in clinically significant prostate cancer detection, especially in PIRATs 3 lesions. And there's a nice study, which I recommend the listeners read, that evaluated different cutoffs of PSA density for evaluating which patients would be found to have bilateral clinically significant disease upon radical prostatectomy, and therefore inferring which patients would have eventually failed a hemiablation. And the study found that a cutoff of 0.05 would be fine to exclude the patient, but it is a really, really low PSA density cutoff. And the study also found that PSA density poorly correlates with tumor upstaging after radical prostatectomy. Therefore, PSA density, at least up to now, is not a really good biomarker for selecting patients for focal therapy, at least at the moment. And how about imaging? I'm not going to spend much time talking about MRI. We had excellent talks in the morning, but just saying that, noting that MRI is very good at detecting where the index lesion is, not so much at detecting the size and the extent of the lesion. So, as we've talked all morning, MRI has its own limitations. But MRI can be good to tell us other implications for focal therapy. For example, this is a study that we carried out when I was doing my fellowship at NYU, along with the group at people of USC, saying if evaluating the performance of MRI in detecting which tumors were close to the urethra, this may have implications for cryo, for example. And we found out that MRI has a really, really good positive predictive value on evaluating tumors close to the urethra. Doesn't have a great sensitivity, but at least the positive predictive value is really good. Also, MRI is really good at detecting extracapsular extension, which is a contraindication for focal therapy, at least up to now. And also, MRI is really good at detecting the location of tumors close to the apex. We know that apical tumors are very tricky to treat in most energy modalities for focal therapy, so MRI is also a useful technique for selecting patients, especially when we are starting our learning curve in focal therapy. And what about PSMA PET? PSMA PET is no longer the new kid in the block. It's now an active player in the main team in prostate cancer treatment. But what role does it have in focal therapy? We also had great talks about this in the morning. This is a nice study, a retrospective study of a really big cohort of patients that underwent both MRI and PSMA PET prior to radical prostatectomy. And they found that the foci that were found on PSMA PET, there really was no statistical difference in foci or index lesion detection between PSMA PET or MRI. But there's an inherent bias on this study. Why? Because if you see the cohort of men treated, evaluated here, well, most fall under, have a really high risk category, which is not surprising because most men that had, given that it is a retrospective study, that had PSMA PET and MRI prior to prostatectomy may tend to be a higher risk patients. And Dr. Strickler just talked about this study earlier in the morning, and which was recently published. It's a retrospective study evaluating men with intermediate risk disease who underwent prostatectomy and had PSMA PET and MRI, similar study that we've done before, but this study only included men that were fit for focal therapy, would have been fit for focal therapy before. And what they did is that they evaluated 4 quadrants on each of the patients. So 138 patients gives you 552 quadrants. And what they found is that using the combination of PSMA, MRI, and biopsy has a higher performance than using MRI and biopsy alone, a higher sensitivity, and a slightly lower specificity. So PSMA PET can also aid in helping us to decide which patients are better for focal therapy. And what this study also found is that 33% of these patients would not have been good candidates for focal ablation because they would have had clinically significant prostate cancer in more than 2 adjacent quadrants. And the addition of PSMA PET would have identified more than half of these patients. So the combination of PSMA PET, MRI, and biopsy would have only missed 14 patients not candidates for hemiablation, most of them with low volume disease, and would have wrongfully excluded 3%. And so what other studies, what other modalities we have on the horizon? We talked about, Dr. Turkbeck gave a nice talk about AI for MRI reading, and we also have contrast-enhanced ultrasound, which is promising. New MRI modalities, the 7 Tesla, for example, and of course the micro-ultrasound, which we also discussed. These are very promising, and there are not yet studies evaluating its utility in focal therapy candidate selection. So to sum up, I believe that traditional risk stratification tools fall short for focal therapy patient selection. Validation of already approved liquid or tissue-based biomarkers in focal therapy population are weighted to assess their role to see if we can really use them. Evidence from some tissue biomarkers, I believe, may help evaluate which low-risk patient may benefit from therapy and for focal therapy. Multiparametric MRI is crucial for patient selection and treatment planning, but it is not perfect. And evidence is growing on the role of PSMA PET for patient selection of focal therapy. Thank you very much.